Hello, I'd like to welcome you all to our event today on protecting milestones, ending childhood malnutrition. My name is Peggy Walters and I'm UK Communications Director at the IRC, the International Rescue Committee. I'll be your moderator for today's event. Thank you for joining us. Now, before we begin, a few items to note. This event will be recorded and we will share the recording post the event. Now, thank you to all of those of you who have submitted questions whilst registering. We have some great questions lined up for our speakers. We'd like to encourage you to continue to submit your questions using the Zoom Q&A function in the bottom of your screen. We'll select as many as we can, as time allows, and during the Q&A at the end of the session, we'll start to ask them. Now, we have some great speakers joining us for this exciting event, so let's get started. It's my pleasure to introduce the IRC's President and CEO, David Miliband, to tell us more about UK Aid Match, our campaign, and the IRC's ambition and approach to investing in malnutrition. Thank you, David.
Thanks, Peggy. Really nice to be with you. I'm afraid it's not good evening for me yet. It's good afternoon. I hope you can hear some sirens behind me. That's because it's New York and it's 1 o'clock in the afternoon. Can you hear me okay, Peggy?
I can.
Yeah, great. Really nice to be with you all. I happened to notice that as I was making my way here and testing the patience of Peggy and others that are cutting it a bit fine, I flicked through my Twitter feed and I saw that Sue Thomas had said on Twitter, "Oh my God, I'm nearly late for my meeting with David Miliband," and that made me hurry up. So to be here on time. Sue, nice to see you on the participants list. I'm really the warm-up act today for Jeanette Bailey, who's worked over the last 5 or 6 years with me on a really fantastic, really important campaign to tackle acute child malnutrition. And I want to put that in a little bit of context over 5 minutes or so, and then let Jeanette give you some of the details. So just for starters, some of you are long-term supporters of the International Rescue Committee, others are not, and will be joining for the first time the IRC family. We're a global humanitarian charity founded by Albert Einstein in the 1930s in New York to rescue victims of the Nazis. And today we're a large global humanitarian charity that focuses on the arc of crisis, from war zones like Ukraine today to internally displaced people, helping internally displaced people, Syria an obvious example, to helping refugees, whether they be Rohingya fleeing from Myanmar, or Syrians fleeing from Syria, or South Sudanese fleeing from South Sudan. Obviously, a lot of attention at the moment is going on Ukraine, which in many ways is the capstone of what I call the age of impunity, a time when the rights of civilians in war is being compromised as never before, or at least as never before since the Second World War. But one of our jobs at the IRC is to make sure that while we respond to acute crisis, we don't forget chronic problems. And some of those are geographic. We have 3,500 people working in Afghanistan, in 11 provinces. We've got major teams in Yemen, in Syria, and elsewhere. But we also think sectorally about some of the big grievous problems that continue to afflict the lives of our clients. And malnutrition, and especially acute malnutrition, especially among children, is a major campaign of ours. And it's a campaign that involves our brains, not just our hearts. It involves our research as well as our programming. Just to give you a bit of perspective, there are 50 million kids under the age of 5 today in the world who are acutely malnourished. There are about 18 to 20 million of them who work in fragile and conflict states, so the kinds of places that the IRC works in. They are notable, these 50 million people, for the fact that 80% of them get no help from the international system. The systems that have been created to tackle acute malnutrition don't work well. Just to give you an interesting comparison, there's about, I think the figure is about 37 million people around the world have AIDS. 76% of them get support from the humanitarian system. We're talking about 50 million people, 80% of whom get no help at all. And we've made it our mission, Jeanette's been leading this over the last 5 or 6 years, we've made it our mission to figure out how to change the system so that we can better help and help more of the acutely malnourished. And that involves fundamental change, because as you'll hear from Jeanette, the current system divides severely acutely malnourished children from moderately acutely malnourished children. We think that makes no sense at all, because it's the same condition. And the moderately acutely malnourished become severely acutely malnourished. And even those who are treated with severe acute malnutrition can often end up stuck in moderate acute malnutrition. And we think we've found a way to empower community health workers, people in the community, parents and carers, to make fundamental change in the way acute malnutrition is diagnosed and in the way it's treated. But we need your help to make this not just a partial solution, but a comprehensive solution. And we're trying to work with UNICEF and other UN agencies who are leading or are given formal leadership roles in this. But we've used our own muscle to develop what I think is a really exciting new way of tackling acute malnutrition. And the final thing I just want to say is that one of the temptations for charities, for NGOs, is to talk about the suffering. What you'll hear today is not about suffering, it's about solutions. We're a solutions-focused NGO that's trying to do better ourselves, but also help change the humanitarian system, because we think we have a responsibility as an NGO that's not a general anti-poverty NGO. We're focused on victims of crisis, people whose lives are shattered by conflict and disaster. We think we have a responsibility to not just be the operational leaders of the humanitarian sector, but the thought leaders of the humanitarian sector. And I think that the work on malnutrition is an extraordinary emblem of that work. It'll give you an insight into how we've become the largest impact evaluation agency in the humanitarian sector, and it'll also give you an insight into the kind of change that we think we can make, not just in our own work, but in the work of others. So Jeanette, with that build up, with that appetizer, I'm happy to hand over to you, and then I will be on hand for any of the easy questions at the end, and the difficult questions will get put on to you. So Jeanette, with that, over to you.
Before we go into Jeanette, thank you, David. Thank you for joining us and for being here to launch this important campaign. Just a quick reminder about this UK aid match opportunity. The campaign will be running from now until the 3rd of August. And during this period, your donation will be eligible for a triple match from the UK government and from a generous IRC supporter. Now, the link for the campaign has been dropped in the chat below. So
now Peggy, you warned me of this. You warned me not to forget to mention the UK aid match, and I completely didn't follow your script. So I know this was not in the script, but let me just reinforce your point, because otherwise I won't have done my job as you required me to do it. This is actually a good area where the government are doing the right thing. The UK government are doing the right thing. They are supporting this. Every pound that we raise will be matched by the UK government and by this anonymous donor. So triple the value, genuine public-private partnership. So apologies, Peggy, mark me down for not having done the right thing in flagging this genuine partnership, but we're very grateful to the government. We think they've done a really good thing in offering to match this, and we really want to maximize the match that they offer by maximizing the donations that come in. So apologies, Peggy, and thanks everyone.
That's right. Thank you, David. Thanks for reiterating that. So now that we've spoken about the IRC's ambition in tackling malnutrition, good time to turn to Jeanette to talk about some innovative research that's driving our nutrition program and their outcomes. Jeanette Bailey is our malnutrition research and innovation lead at the IRC. Jeanette, thank you for joining us.
Thank you,
now,
Peggy.
Wonderful, thank you. If I could start by just asking you if you could tell us a bit more about how malnutrition and displacement are connected.
Well, it's a complex topic, and the truth is we expect in the coming few years for malnutrition in young children to rise, potentially quite drastically. And this will be due to climate change. It's already due to conflict. And the last few years, we've seen a major challenge to the livelihoods of communities we work in due to COVID-19. So there are a lot of drivers of childhood malnutrition right now. And the reality is it is a public health emergency. It's on par with COVID. It's on par with the HIV/AIDS epidemic. As many children have died of COVID in the same amount of time, as many people have died of COVID as have died of malnutrition in our youngest children under 5. So it really is a public health emergency. And when we talk about displacement, we're looking at communities that are already very vulnerable. And when you are forced away from your home, you're forced away from livelihoods, from livestock and crops, from healthcare, from community support, from coping mechanisms. People and families and communities have a network, a web of resilience that they build at home to weather crises. But when they're forced away from their home, all that falls apart. So when we see that those coping mechanisms are disrupted, that's when we start to see malnutrition continue to increase.
Thank you. Thank you for sharing that with us, Jeanette. Can you just touch upon what you've learned from your research that allows for more efficient and effective treatment?
I'm happy to speak about our research. As David mentioned, I think this is a really exciting area of work for us at IRC, and we've built up a really strong infrastructure at IRC to support research in humanitarian contexts, which is really quite unique. So what we've focused on is 3 key areas, 3 key solutions to end childhood malnutrition. The first, as David mentioned, is that we want a very simple treatment protocol, a protocol and an approach that can be scaled up cost effectively. Because as David mentioned, 80% of kids who need treatment are not receiving it. That's the status quo today. So we need a much more nimble, streamlined system to get care to all the kids who need it. So the first part of that is we simplified the treatment protocol. We combined the treatment of severe and moderate malnutrition into one simple protocol. And we tested this rigorously, starting with a clinical trial, a gold standard trial 5 or 6 years ago, and now expanding into a number of different operational research trials in many of our IRC countries. We're also supporting partners and UN agencies to replicate research and test out this approach in a lot of other countries as well. The second solution that we're working on is training community health volunteers at the village level to deliver treatment so that families don't have to travel long distances to reach a health facility, because that is often not possible due to conflict or even due to climate change when you have a lot of flooding or other disruptions to road systems. So having care close to home is really important, and using trained community health volunteers gets care out of health facilities and into communities. And the third solution that we're really invested in bringing to scale is the family MUAC approach. So empowering moms and dads and caregivers to identify malnutrition in their own children using this really simple mid-upper arm circumference tape. And when a child is red, this means they have severe malnutrition, yellow is moderate malnutrition, and green is still okay. That's a really simple tool that we want to get into the hands of families. So that 3-part solution is what we've been generating evidence on for the past 6 or 7 years.
Thanks for that, Jeanette. And I'm wondering, is it possible for you to just briefly walk us through the process of designing and implementing a nutrition program?
That's a great question, Peggy. I'm laughing because I teach an entire class at Columbia University on that topic. So let me see if I can get that down to a few key points. First, we assess the situation. And that might be through a survey where we take a representative sample of the population and see how many children are malnourished in that sample. But if we know that there's already an emergency and we have reports from the field saying we're seeing lots of malnutrition, we've got people who are very ill, we've got disrupted health systems, we won't take the time to go ahead and do a lengthy, expensive survey. We will go right in and start our programming. And so the first piece of that programming puzzle is to work with local communities. We consult with community leaders, we evaluate the local infrastructure, and the local resources. Because our goal at IRC is to support existing health systems. It's not to replace the health system. So we really look at those local resources. And there are a variety of programming approaches we may select. If we see a lot of malnutrition in young children, we'll set up a treatment program. But we may not see a lot of malnutrition. And instead, we might see food insecurity or an outbreak, and we might predict that in a few months, we will see a lot of malnutrition. In that case, we'll do a prevention program. Perhaps we'll distribute a supplement to young children and pregnant and lactating women so that they can not develop malnutrition. Another programming option is supporting breastfeeding in mothers of babies. So there's a lot of options we'll choose from depending on the situation that we assess. And finally, after we've set up the program, we continue to evaluate. And that's really important because 6 months down the line or 12 months down the line, the situation will continue to evolve. We want to make sure the programs we set up are matching the needs, and also that the communities are accepting the program and are engaged with what we're doing. So we'll continue to evaluate after the program is rolled out.
It's great. And you talked there about, matching the needs of programs to the communities. Can you just give us a sense of how programming design differs from country to country? Can you give us an example, for instance?
Sure. Programming will change country by country, but even within countries, programming needs to be very context specific. So there's certainly no one size fits all approach or solution. And we really do look at each context very specifically to select what kind of programming we're going to pull together. So to give some examples, right now in Yemen, and in Afghanistan and in a few other countries where we have conflict, we rely a lot on mobile health teams, mobile clinics to deliver care. Because in those cases, we don't want families to have to travel to a health facility and risk themselves in the process. So we'll have a health team that's in a vehicle, they'll drive to an appointed location at an appointed time, and the community members know that they can go there on that day and receive treatment for their children. So that mobile health clinic approach is really important in Yemen and Afghanistan. In Somalia right now, and beginning in some of our other countries, including Syria, we're using the simplified protocol, really looking at alterations in the protocol so that we can treat more children more cost effectively. And then finally in Nigeria, we're using what we call the Mama MUAC approach. And my colleague Mercy will be sharing more detail on that. But that is, again, empowering mothers to identify malnutrition in their own children.
Wonderful. And I guess, is there any aspect of your work that you're most proud of from IRC's malnutrition work?
Yes, I would say that there's so many humanitarian organizations and local organizations. Everyone is doing good work. Everyone has that goal of ending childhood malnutrition. But I think what I'm most proud of at IRC is that we have never accepted the status quo. We have always challenged it and pushed the envelope to think differently. And so 6 or 7 years ago, we started to think of new solutions to address the widespread malnutrition that we were seeing. And we didn't just think of those solutions, we invested heavily in the research infrastructure to generate evidence around those solutions. So, as I mentioned, the research process, starting with clinical trials, expanding to operational research, and now supporting partners to scale up new approaches and try to reach more children with care. I think that's what I'm most proud of, is that very innovative spirit.
That's wonderful. Jeanette, thank you. It's so fascinating to hear the science behind our malnutrition programs and how through this kind of innovation, we can reach more children more effectively. Definitely a golden thread through listening to you talk was how we're thinking innovatively, almost innovatively thinking outside of the box around how we are challenging malnutrition in the countries that we work in. Now, this is a great transition to turn to the deliverables of the work we do on the ground, particularly in our Nigerian malnutrition program that the UK Aid Match campaign will be funding. Now, to show us around the clinic and to see more of our work in action, we'll first watch a video hosted by our very special patron at the IRC UK, His Royal Highness, the Prince of Wales.
50 million children worldwide suffer from acute malnutrition every year. Conflict and climate change mean families can struggle to access the food and medical care they need to ensure their children reach critical developmental milestones and give them the best start in life. Recently, as a patron of the International Rescue Committee, I had the opportunity to pay a virtual visit to Nigeria. I heard directly about the vital and innovative work the IRC is doing to treat children with severe acute malnutrition in northeast Nigeria. Last year, the IRC treated 161,000 children under 5 years old around the world for severe acute malnutrition. However, as drought and conflict continue to create massive food shortages in places like Nigeria, Afghanistan, Syria, and Yemen, parents are left struggling to provide nutritious food for their children. Now, more than ever, it is critical that the IRC is able to reach children and their families in Nigeria and worldwide.
I'd like to now introduce Mercy Alriji, IRC Deputy Director of Programs for Nigeria, to tell us more about the program in Nigeria and what they're hoping to achieve. Mercy, thank you for joining us.
Thank you, Peggy, for having me on this event.
Thank you. Now, first of all, can I just ask you, how did you first come to the IRC and get involved in this work?
I joined IRC over a year ago, that's in February last year, as the Deputy Director of Programs for IRC Nigeria Country Program, with 18 years experience in humanitarian assistance. Northeast Nigeria has been in a conflict for over 10 years. The attacks and insecurity has displaced many people, devastated agricultural production and other livelihoods, and also essential services have been impacted. With the onset of COVID-19, the number of people in Northeast Nigeria that needs humanitarian assistance has basically spiked up to 10.6 million, and another 3.8 million struggling to access food. And this year, it is estimated that 320 children are having at risk of acute malnutrition in Northeast Nigeria. Now with this, I got involved in IRC work in regard to ending the preventable deaths of children, of newborn babies due to poor nutrition.
Brilliant, thank you. Thank you for sharing that with us, Mercy. So we were able to see the works of the clinic in the video, but could you tell us just a little bit more about the key tools that you're using to tackle malnutrition through the program?
Thank you. That's a good question. Community management of acute malnutrition is the main approach that IRC is using in Nigeria for treatment of acute malnutrition. And it has several components to it. One of it being, like Janet had mentioned, the Mamamu approach, whereby we train health workers, volunteers, and also caregivers to undertake the screening and referrals or self-referrals of children to promote early health seeking behaviors amongst the community. Another is basically establishing and training support to mother support groups, whereby we promote breastfeeding, and the women get counsel, get supported from the mother support group. Another approach that we also use as part of the community management of acute malnutrition is the father to father support group, whereby we promote best practices in infant feeding, and also using locally available food to promote the locally available food to manage the malnutrition cases. Now, specific to the father to father support groups, I just wanted to mention we target the fathers basically because it is important to have behavioral change and practices on infant feeding also with the fathers or with the men, because in the context in Northeast Nigeria, they are the key decision makers at the household level. And so it is important that they are also targeted in this approach. The other approach that we have is basically the outpatient treatment centers. This outpatient treatment center is basically, we provide treatment to outpatient treatment for acute malnutrition. And we, in this project, we are going to target 8 outpatient treatment centers to be able to support the children with that have acute malnutrition. Another is also, like mentioned already, for children that have already like acute medical complication, we the approach we are using is placing them in a stabilization center and being able to support them with 24 medical attention and feed them every 3 hours. And this is important because the children are in very fragile state, and so they need close monitoring and support. So that is one of the key approach or tools that we use. And in all these approaches, we work closely with the state Ministry of Health, basically that is the State Primary Health Care Development Agency, whereby we formally also train their staff to basically and also provide on-job training for them. Our technical staff are able to provide that on-job training. And this is basically to ensure that we are living in place systems, and we are also strengthening systems and ensure that there's sustainability for the project moving forward. On that also, I just wanted to highlight that training healthcare workers on inpatient care, we basically also use the Ministry of Health guidelines and specific also the Nigerian Ministry of Health approved protocols for managing malnutrition. So in summary, in all these, the various approaches or tools we deliver, I've mentioned, we are able to deliver care for acute malnutrition through a comprehensive approach and offering promising, stretching every pound for treatment of malnutrition. So these are the deliverables that I just wanted to highlight as the in this section. Thank you.
Mercy, thank you. Thank you for sharing your comprehensive approach to this work. Now, a large part of the program, as you've touched upon, is related to community-based malnutrition treatment, like the mother-to-mother support groups that you just shared with us. Can I just ask, how do you ensure rich community engagement and community-based management? And can you just tell us why this is so important to the success of the work that you're doing?
Yes, Peggy, it is really very important to engage community in all aspects of nutrition programming, and specifically for us in Nigeria, this is a very key component. One is basically we create awareness on malnutrition to promote healthy behaviors amongst the community the community population. And two is basically to actively engage the community leaders and members to ensure real program ownership. You know, engaging the community leaders basically promotes real program ownership, but also acceptance by the community leaders and the community. And also that supports in itself identification of the most vulnerable children or that are at risk in the community. And so this is for us something which is important to ensure that the long life of the program. The other component of this is basically due to unpredictable security context in Northeast Nigeria. It is actually safer and easier to reach inaccessible or hard to reach locations through having these community structures, like I mentioned before, the mother-to-mother support structures or the father-to-father support structures. And through that, we are able to reach even areas that are insecure or hard to reach. And so that is very important to us, especially like also when the Mama Mua approach that has been highlighted before, basically enables the community to be able to monitor the malnutrition cases without the presence of any technical health worker, but manage it by themselves. So that is very important to us. So men and women have key roles within their families and the nutrition of their family. And so like we all know, women are always the caregivers in the context of Northeast Nigeria, and the men are the decision makers in the family. And so it is very important that we do engage them, especially on issues to do with food availability and also having nutritious food at the family level. And lastly, I will say that the benefit of community engagement in overall really helps us in the short term to easily reach with our deliverables and save lives, but also while on the long time to be able to sustain the program. And also that is feasible given that we also train the community health volunteers, but also the Ministry of Health staff in managing acute malnutrition.
Thank you for that, Mercy. You touched upon, the ambition of the program to reach more vulnerable people in more remote, hard to reach areas. Could you tell us a little bit more about the tools that you're using for this kind of outreach?
Yes, many communities in the Northeast Nigeria are still hard to reach, like already mentioned. They are very inaccessible due to insecurity. And so, and that's why for us, it is important that we ensure that the mothers and children are really supported, because most of them get locked up in these areas that are very inaccessible. So we promote, basically, we are able to reach these communities and then support these children with the healthcare services. Like I mentioned earlier, that because of the insecurity, the health system has really broken down, but also most of the health facilities, like mentioned, has been destroyed, and those that are operational are actually not operating in its full capacity. So with this situation, the issue of malnutrition has been aggravated more because of the context that we are working on. But as RSC, we have used actually innovative approaches or tools to ensure that we are able to reach wider community, even the inaccessible community. So how we do that basically is that RSC has trained, we have trained community structures, community local structures, like I said, the community health workers who are based in the community and are able to mobilize and sensitize the community on the malnutrition and the causes, and also how that can be managed, especially also ensuring that there's behavioral change for early, for the communities or mothers to be able to seek medical services in time. The other approach is basically the community-based management of acute malnutrition. 85 of severe acute malnutrition cases in the Northeast are actually being managed from the community without referrals to a stabilization center or for inpatient care. And this is because the community are able to manage it at the community. And for us, that is really very cost effective, because we are able to manage malnutrition at home level or at the household level or in the community. So that is very important and critical for us. And also the Mama Mua approach that we have highlighted, where mothers are and caregivers are able to be trained to basically take measurement or are able to identify and refer children with acute malnutrition at the community level. Now, this enables mothers to do early diagnosis of their children and in case they are wasting, but also be able to seek early treatment for children that have been identified at risk. But also this enables us to scale up in terms of our program, but also ensuring that we improve the infant and young children feeding mechanism and practices. And so that is the key. And lastly, I will say that one of the tools we work with also is to work with local organization. Now, specific for this program, we have a local organization called Green Code that we are going to work with to have a better understanding of the local contacts and be able to engage the community and also be able to mobilize the community. With this, we are very sure that this will improve community participation, acceptance, and ownership.
Wonderful. Thank you for sharing that with us, Mercy. And just finally, so this is a 2-year program of funding through UK Aid Match. If we're looking on 2 years from now, can you just share with us what the expected goals are and the outcomes that you're hoping to achieve with the program?
Yes, Peggy, before I go that, I just want to share a story. I was last week visiting I was in the field monitoring and supporting our teams in the field. And just peg that to the question in terms of how we support our work and tools that we reach, support the communities or the mothers and children who are in the remote areas. I met one lady called Aisha who has a kid who was suffering from acute malnutrition. And Aisha basically lives in one of the remote communities in Nigeria, in the northeast Nigeria. And she was not able to take the child to the hospital because of that. However, what happened is that together with the husband, and the husband being the key decision maker in terms of the health or the food of the family, had actually asked Aisha not to seek medical attention, but instead use the traditional means to be able to treat. However, Aisha's story was so compelling because she said, with the support of the community volunteers that actually visited her, the RRC trained community volunteers that visited her home and was able to identify through the Mama Mua approach, and take measurement, and then be able to identify that the kid at risk, because the baby had stayed actually now a year and had not started walking, and she was so concerned about her child. And so what happened is that Aisha was telling me that once that happened, she was worried when she was being referred that she needed to go to RC outpatient clinic support. The fear she had was that the husband will not be able to accept her to go. But when she shared that challenge with the community volunteer, then the community volunteer was able to reach out to the Bulama. The Bulamas are the community leaders in the community. And the Bulama was able to also see the importance for that child to be taken to the hospital, and physically, personally, took it upon himself as a decision maker, as a community leader, to talk to the father of the child, the husband of Aisha. And with that, Aisha was able to access RC services at the outpatient clinic care. But then also when she reached there, basically, she also found that the RC health team basically did the same measurement and realized that this baby is in a critical condition and needed to be moved to the stabilization center. Now, by the time I was visiting and meeting Aisha, Aisha was already out of the stabilization center with the baby. She was so excited that the baby had gained good health and the baby is already back in the family. They were together with the family. But there's something which was so compelling to me that Aisha basically highlighted, that when she was in the stabilization center, she was also trained how to use the mama muak. And she said that knowledge alone is very important for her, because right now she's able to also monitor the health of her other children, but also will continue supporting other women or other families in the community. But also she joined the mother-to-mother support groups to basically be a voice to the community and also support the community. So that is how important it is to engage the community and have the community-based management of acute malnutrition. So that's how Aisha's story basically illustrates and how important it is. Now, coming back to the question that you highlighted in terms of our expected goals outcomes. Now, this is going to be a 2 years project. So in 2 years from now, RRC main goal is to ensure that we are contributing to ending preventable deaths of mothers, new babies, and children under 5 due to poor nutrition, but also with 133,667 children under 5 and their caregivers and pregnant and lactating mothers have increased access to skill support for breastfeeding, for access to nutritious food intake, and also quality treatment for acute malnutrition. So our overall goal is to have over 3,000 clients and all community members participate in community-based problem solving for acute malnutrition. And for us, this is the most sustainable and effective way of managing malnutrition.
That's wonderful, Mercy. Thank you so much. Thank you for sharing that wonderful story about Aisha, who came back to effectively volunteer. And it's great to hear the detail of the program in Nigeria and the ambitions for the program as well. So, as I mentioned at the start of the event, we're now going to bring our speakers back to take some questions from you, the audience, that have been submitted through the Zoom function. Let me see. Now, first question for David. David, how can you tell us how we can guarantee that fundraising money reaches the right people and places?
Sure, thanks. The simple answer is that we've got people on the ground. So I've been to Northeast Nigeria twice, actually, and seen the work that's going on there. And we have an infrastructure of a country team. We have the right compliance and mechanisms. And above all, we have the people to deliver the services. And seeing how our outreach workers go and identify those families in the community who are most at risk of acute malnutrition, who then train the mainly mothers, but parents and carers to make sure that they're able to be supportive of the kids and diagnose appropriately using really simple but effective techniques. And then the prescription for how to support it. We're very clear about the delivery mechanism. And so I think people can have a lot of confidence. There's a real focus here that can make a difference. And Northeast Nigeria obviously isn't the only place that's suffering from acute malnutrition, but we are, is it right, Jeanette? We've got it in 12 or 13 countries now. We're using the combined protocol.
That's right, David. Yeah.
Lovely. That's really helpful. Thank you for that, David. And just another question coming through. In some societies, girls are disproportionately deprived in terms of access to food and education. How do you readdress the balance? Jeanette, a question for you.
How do we address that imbalance between that gender disparity in treatment? Is that the question? Yeah. At IRC, it's it's a common theme and thread across all of our work to look at women's empowerment and to look at women's and girls and the challenges that are stacked against them in comparison to the broader population. And it is interesting when you look at the children who are becoming malnourished, there is often this gender disparity. We have found that boys seem to be a little more vulnerable to malnutrition just physiologically, and yet due to societal reasons, you'll see more malnutrition often in girls. And so the way we can address that is integrating more, and we do this with our women's protection and empowerment programs and our child protection programs, because the answers are not all packaged up in one malnutrition solution, for example. It's really about that integration with our gender equity colleagues and teams.
Great, thank you for that. Thank you for that, Jeanette. And just looking at another question that's come in, is lack of food the major cause of childhood malnutrition in the countries where you work? One for Mercy. You're on mute, Mercy.
Sorry. Yes, food insecurity is basically not the only cause of food malnutrition. There are also other causes of food malnutrition, like malaria and other causes and other causes. So I will say that food security is not really the cause, but one of the main, given in the context of Northeast Nigeria, whereby access to farmland has been a challenge, access to food. Most people are still living in IDPs and needed to still have access to food. But like I also mentioned, there are children who are living in hard to reach areas that do not have access to food and do not have access to actual also other medical services. So I'll say, yeah, that food security is one of the major, but it is not the only cause for malnutrition in Nigeria.
Great, thank you. Thank you for that, Mercy. And we're almost at time. We're nearly at the close of our event. I'd like to thank all of our speakers for joining us, and for you, the audience, for joining us, and for the great questions that you've submitted. Now, if you felt inspired by IRC's work, the work that was outlined in our event today, please do consider donating today to our Protecting Milestones appeal. Now, up until the 3rd of August, for every £1 donated to the IRC, the UK government will contribute £1 of UK aid to fund our new programme treating malnutrition in Nigeria, up to £2 million. An IRC donor will also match the original donation, meaning that your gift will go 3 times as far. Now, with your tripled support, it means the IRC can reach 3 times as many parents to help their children reach these precious milestones. Now, for all of you who have already donated, we can't thank you enough. Thank you for taking part in this special opportunity. Now, we've dropped the donation link in the chat if you'd like to support our work. And I want to emphasize that it's only through the generosity of donors like yourselves that we're able to achieve any of the work that we've discussed today, that Mercy and Jeanette have shared with us today. Now, we'll follow up with information and a recording following the closing of this event. But if you'd like any more information, please don't hesitate to reach out to us and we will happily stay in touch with you and give you more information. Thank you so much. Thank you for joining us.